بسم الله الرحمن الرحيم. السلام عليكم أعزائي الطلبة. Our lecture today is about abdominal aortic aneurysm, AAA. What is an abdominal aortic aneurysm? An abdominal aortic aneurysm is a permanent localized dilatation of the abdominal aorta, about 1.5 times greater than the normal diameter of the artery. Epidemiology. Incidence of AAA is estimated between 4% and 8% of the male population aged 65 years and older. Comparatively, it is between 0.5% and 1% in females of the same age. An estimated 80 million people aged 60 years and older are at risk in Western Europe. The frequency is much higher in smokers than in non-smokers, about 8 to 1, and the risk decreases slowly after smoking cessation. So imagine how smoking is important in the development of AAA. In USA, the incidence of AAA is 2 to 4% in the adult population. AAA is the 12th leading cause of death in Western societies. It is a silent killer because there are often no symptoms that an aneurysm is developing in the abdominal aorta. Rupture of AAA occurs in 1 to 3% of men aged 65 or more. The mortality is 70 to 95%. I mean the mortality of a ruptured abdominal aortic aneurysm. Did you know that Albert Einstein died from an abdominal aortic aneurysm? Now, what are the risk factors of AAA? First, smoking. More than 90% of people who develop an abdominal aortic aneurysm have smoked at some point in their lives. Second, alcohol and hypertension. Genetic influence. Family history is present in about 20% of cases. Alpha-1 antitrypsin deficiency. Connective tissue disorders such as Marfan syndrome and Ehlers Danlos syndrome have also been strongly associated with AAA. Atherosclerosis, infection, trauma, arteritis, and cystic medial necrosis. COPD is also reported as a risk factor of AAA. Pathophysiology. The most striking changes are seen in the tunica media and intima layers. So the changes are mainly in the intima and media of the aorta. These changes include the accumulation of lipids in the informed cells, extracellular free cholesterol crystals, calcification, thrombosis, and ulceration, and rupture of the layers. Adventitial inflammatory infiltrate is also present. However, the degradation of tunica media by means of proteolytic process seems to be the basic pathophysiological mechanism of AAA development. Some researchers report increased expression and activity of matrix metalloproteinase in individuals with AAA. This leads to elimination of elastin from the media, rendering the aortic wall more susceptible to the influence of blood pressure. Other reports have suggested the serine protease granzyme P may contribute to the aortic aneurysm rupture. Now, classification of AAA. You have two types of classifications. Morphological classification and size classification. Morphological classification, we have true aneurysm involving the whole wall, either fusiform or saccular, and pseudo-aneurysm, part of the wall of the aorta. Size classification, ectatic or mild dilatation, less than 3 cm, moderate 3 to 5 cm, large or severe, more than 5 cm or more than 5.5 cm. Now, what are the clinical features of AAA? First, asymptomatic. So AAA can be asymptomatic, and it can be diagnosed or found incidentally during a physical examination of the abdomen for another reason, or during doing abdominal x-ray or abdominal ultrasound for another reason. Or it could be symptomatic, but the patient is hemodynamically stable. That's to say, symptomatic AAA without rupture, without bleeding. What are the symptoms of symptomatic AAA but without rupture? Abdominal, abdominal pain, back pain, or flank pain. This pain may radiate to the groin, thigh, or testicles. This may be due to sudden expansion of the aneurysm or compression of the adjacent structures. Third clinical presentation is a ruptured AAA. So the presentation is either asymptomatic and found incidentally, or symptomatic without rupture, or ruptured AAA. The patient with ruptured AAA may present with back pain, hypotension, and pulsatile abdominal mass. This classical triad is found in less than 50% of the cases. Ruptured AAA means bleeding. The bleeding can be retroperitoneal or into the abdominal cavity. Rupture can also create a connection between the aorta and intestine or inferior vena cava. Also, you can find flank ecchymosis, appearance of bruise in the flank. It is a sign of retroperitoneal bleeding, and it's also called Gray Turner's sign. The mortality of rupture is as high as 90%, and about 65 to 75 of patients die before they arrive at the hospital, and up to 90% die before they reach the operating room. So imagine the risk. Now, any AAA with symptoms assume rupture until proving otherwise. This is very important. Any AAA with symptoms assume rupture until proven otherwise. Now, what are the other causes of Gray Turner sign, which is ecchymosis in the flank? Acute pancreatitis, pancreatic hemorrhage, retroperitoneal hemorrhage, blunt abdominal trauma, or hemorrhagic ectopic pregnancy, or spontaneous bleeding because of coagulopathy, and of course ruptured aortic aneurysm. Now, diagnosis of AAA. First, history. Of course, as I said before, family history is present in about 20% of the cases. Also, you have to ask about hypertension, smoking, which is very important, and other risk factors. Second, physical examination. You can find pulsatile abdominal mass in the epigastric area during examination of the abdomen, either visible or palpable. But this pulsatile mass is found in about 25 to 30 in about 25 to 50% found not palpable. Imaging of AAA. First, plain abdominal X-ray may show the outline of an aneurysm when its walls are calcified. But X-ray cannot measure the size or determine the rupture. So it is helpful only if there is calcification in the wall of the AAA. Abdominal ultrasound, it's an extremely sensitive test for all AAA sizes. It is painless, of course, and non-invasive, and it is cost-effective and it's highly diagnostic. This picture showing AAA diagnosed by an abdominal ultrasound. Other test, CT scan or CT angiography. It will give accurate diagnosis and it will give the exact diameter of the aneurysm extent, and it will discover any signs of rupture. Another picture of CT angio of abdominal aorta, CT angiogram. Now, another test used in the diagnosis is MRI and angiography. Okay. Now, what are the complications of AAA? Rupture is the gravest and most common complication, and it's a very serious complication. Other complications include peripheral embolization, aortic thrombosis, fistula formation between the aorta and duodenum, or between the aorta and inferior vena cava, aorto-duodenal or aorto-caval fistula, local compression, mass effect, and hydronephrosis. Now, differential diagnosis. By differential diagnosis, I mean the differential diagnosis of acute abdominal pain, shock, and back pain. First, myocardial infarction, pancreatitis, perforated viscous, mesenteric ischemia, renal or biliary colic, and lumbosacral disc disease. This is a differential diagnosis of AAA. That to say, acute abdominal pain, shock, and back pain. Now, treatment of AAA. We have three groups: asymptomatic AAA, symptomatic AAA without rupture, and ruptured AAA. First, asymptomatic AAA. Confirm that patient is asymptomatic, that the patient is really asymptomatic, and measure the maximum diameter of AAA by ultrasound and consult vascular surgeon for follow-up. This table showing the growth rate per year and annual rupture risk depending on the size of AAA. If you notice here, when the size is 3 to 3.9, the growth rate is about 0.39, and the annual rupture risk is zero, is almost zero. When the size is 4 to 4.9, the annual rupture risk is about 0.5 to 5%. But when the size is 6 to 6.9, the growth rate is about, per year of course, is about 0.64. But the rupture risk is 10 to 20. And of course, when size equal or more than 7 cm, the annual rupture risk is about 20 to 50%. Clinical practice suggests that if the aneurysm diameter less than 4 cm, recall annually. Recall the patient every year for follow-up. But if the size of the aneurysm is more than 4 cm and less than 5 cm, recall every 6 months for follow-up. But if the size more than 5 cm or the patient is symptomatic or the aneurysm is growing by more than 1 cm per year, endovascular and surgical management should be considered. Endovascular or surgical management should be considered. This is regarding the asymptomatic AAA. What about symptomatic AAA? As I said previously, any symptomatic AAA should be considered as a ruptured AAA until proven otherwise. So, immediate vascular surgical consultation is required. You need cardiac monitor, large bore IV access, O2, CBC, type and cross 6 pints of blood, CT angio after surgical evaluation, and admit the patient for repair. What about ruptured abdominal aortic aneurysm? Ruptured, of course, it is a life-threatening condition. So immediately, the patient needs vascular surgical consultation. So immediate vascular surgical consultation, and usually transmit straight to the OR, operating room, without further diagnostic workup. Imaging is contraindicated in unstable patient, IV access, type and cross, etc. If this does not delay transfer to the operating room. So ruptured AAA is an urgent condition. You need to immediately transfer the patient to the OR. So keep calm and call a vascular surgeon in case of ruptured AAA. Now, what are the treatment modalities of AAA? We have open repair and endovascular repair. Open repair of AAA, the patient requires general anesthesia, laparotomy of course, and the retroperitoneum is incised to expose the AAA. Aorta and iliacs arteries are clamped. Aorta replaced with a prosthetic grafts. But this open surgical repair requires significant incision in the abdomen, 30 to 90 minutes cross clamp of the aorta, up to 4 hours procedure. It's contraindicated in some patients, especially old with high risk factors and many comorbidities. It requires 1 to 2 days intensive care, 5 to 7 days hospitalization, 4 to 6 weeks recovery time, and high perioperative mortality with 5% risk of mortality. This picture showing a large AAA needs to be dealt with by a professional vascular surgeon, of course. Now, endovascular repair of AAA. It's less invasive procedure. AAA excluded from circulation with intraluminal stent graft, has lower perioperative morbidity and mortality rates, but may be less durable and requires more frequent follow-up than open repair. Typically reserved for elderly and high-risk patients. Endovascular repair requires either general, regional, or local anesthesia. The approach is from the femoral arteries So femoral arteries should be exposed. A graft is introduced through the femoral arteries, guided into position inside the AAA by fluoroscopic imaging, and then deployed in position. This is the abdominal aortic aneurysm before endovascular graft, and this is after insertion of endovascular graft. That's all about AAA. Thank you very much.